dissection. دكتور سامر غانم. دكتور عاصم النماس. دكتور رائد عقل. دكتور إبراهيم جراد. دكتور عدنان. دكتور محمد مطر.
يعطيكم العافية. هلأ في عنا محاضرة للدكتور قيس بلبيسي from Jordan. You are welcome. It's about keynote lecture about the coronary dissection. تفضل دكتور.
يعطيكم العافية جميعا. مساء الخير وإن شاء الله يعني we're on the last session. Thank you Dr. Mahmoud. Thank you for the organizing committee. عن جد كتير حلو المؤتمر. Cases رهيبة. All the presenters have done an amazing job, so thanks everyone. It's been enriching. Okay, اليوم حنحكي عن coronary artery dissection. هلا there are two big categories with coronary artery dissection: spontaneous coronary artery dissections (SCAD) or iatrogenic coronary dissections. هلا iatrogenic coronary dissections, I'm just going to go over them at the end very quickly because we've extensively spoke about complications. And more importantly is to actually recognize SCAD. So, spontaneous coronary artery dissections. هلا epidemiology. Again, I don't want to bore you with too much information, بس مش غلط نعرف مين هم patients who are susceptible for such a disease. Usually we all know they're young women of childbearing age. It's more with pregnancy, but not necessarily. It can span all the way from adolescent all the way up to 90s. So, few reported cases of SCAD throughout, but mostly they're women and they are of childbearing age, more associated with pregnancy. And 35%, in one report, 35% of SCAD patients were among women less than 50 years old. The median age comes between 40s to 50s. And what I do want you to know is 43% of SCAD cases are pregnancy-associated ACSs. So again, these are the population at risk. Also, another point, SCAD or spontaneous coronary artery dissection is more common in the LAD. It happens around 45 to 60%, but it still can happen in the other vessels. It can happen in the left circumflex, happens in the right coronary, even the left main, spontaneous, I'm talking not the edge, catheter dissection, we're talking about spontaneous dissection, 4%, and multi-vessel can come as frequent as 9 to 23%. So again, there's a variety of presentations. Now, here comes the pathophysiology. Initially, we thought spontaneous coronary artery dissection, there's an intimal tear, blood seeps in, causes the dissection. Well, maybe that's not the right way. There's a new emerging theory, which is the other one. So it's the inside out versus the outside in. Now, the outside in is you have the inside out is that you have the hematoma, which is the new theory, and then it grows and it creates a lot of pressure and it fenestrates and opens into the vessel. So that's the newer theory. The older theory is the outside in. From the vessel comes the tear and fills the vessel. So it seems that the intramural hematoma is the more common pathophysiology. Now, because of that, let's look into the patients of spontaneous coronary artery dissection. We need to think of them in more than one thing. So, first of all, there is a population that are at risk, vascular vulnerability. Which patients are those? Those with fibromuscular dysplasia, those with connective tissue disease, hypertension, pregnants, hormonal changes, those are the patients who have vascular vulnerability. They're more prone to develop disease. Then comes a trigger that causes this. Those triggers can be emotional stress, intense exercise, a rapid change in hormones such as menopause, sometimes pregnancy, sometimes over-the-counter, OCPs, and drugs, whether they're cocaine, amphetamines, or using of epinephrine and so forth. So again, these are triggers on top of a vascular vulnerability that will lead ultimately to SCAD, spontaneous coronary artery dissection. Now, what is the presentation? It is an acute coronary syndrome, right? It can come as chest pains, shortness of breath, syncope, arrhythmias, even cardiogenic shock. What is specifically kind of a red flag is the population. When it happens in a young woman, or it happens in a patient who has the underlying risk factors that we talked about before, or if a pregnant woman, again, this is kind of a light bulb that makes me think this could be a spontaneous coronary artery dissection. Now, the main way to diagnose, of course, we're going to do EKGs, we're going to do troponins, we are going to do an echo, but ultimately, the main methodology for diagnosing SCAD is coronary angiography. And there's a certain classification by Saad et al. For SCAD. To put it in simple words and not to waste time, type 1 is the usual type which we're all aware of. You have this small linear, and within the wall, there is staining because of the spontaneous dissection. This is type 1. This is the one we're used to. Type 2 is where you have an intramural hematoma, and this intramural hematoma is compressing the lumen. Now, this can come as a long lesion, more than 20 millimeter, and you have a healthy segment before and after. This is called type 2A. Now, if this long lesion kind of swifts downward and you no longer have a good healthy lesion distally, it's kind of 2B. Okay? Both are considered type 2, but one is 2A, one is 2B. The third one is the tricky one. The third one is a focal intramural hematoma that compresses it. It looks almost like a atherosclerotic lesion. The only way to diagnose it is actually through intravascular imaging. But it's important to consider it in certain risk patients at risk, because the way of treatment and the way you're going to stent is different a little bit. All right. Type 4 is when you have like a distal embolization and complete occlusion. It's not a common one. Okay. Here, so we talked about how are we going to diagnose. Another tool is intravascular imaging, whether IVUS or OCT. OCT is an amazing tool if we have it. It shows the intravascular lumen with excellent resolution. It doesn't have that much of depth penetration, but it's there. You can see here the false lumen. You can see here the false lumen. And here also, this is the false lumen. And here's the tear, which is usually a decompressing tear. This is a side branch. So you can see that the false lumen does not extend there. IVUS is another good, useful tool. Here you can see the hematoma, but it doesn't have as much good of a resolution. Now, again, coming back to the pathophysiology, there are two potential pathophysiology. One is the tear, the other one is the hematoma. Which one is the true one? Are they a combination? It's kind of still up to debate, but most of the literature leans toward the intramural hematoma. All right, so what are we going to do? The main question we're going to ask ourselves is how stable is my patient? Because the main goal is to be as conservative as possible. As conservative as possible. You really don't want to go mess around with such a dissection. Why? Because there are so many potential complications if you do go in with your intervention. You could first go into the false lumen, and if you stent or balloon that, you're going to have no flow. If you do what we call toothpasting, if your stent is too short and you press the intramural hematoma to the sides, it's going to dissect more proximally and distally, and then more proximally and distally until you reach the distal left main. That can be a disaster. Or with time, when that hematoma goes away, you're going to have a malapposed stent, which is increasing your in-stent thrombosis. So you really don't want to mess around with a spontaneous coronary artery dissection if you can. So if your patient is stable and doesn't have ischemic symptoms, and there is not much of electrical instability or hemodynamic instability, the main goal of treatment is going to be medical. It's tough to do, but that's what we should do. Now, if you have those, if your patient is unstable, they're having a lot of ischemic symptoms, they're, have poor flow, big territory, then you have no choice. So, few procedural tips. Number one, you want to use a long stent, okay? You want to have it 5 to 10 millimeters on both proximal and distal edges of the area that you're looking at. Why? Because the toothpasting effect. You don't want that hematoma to extend. So you want to come well beyond both edges and cover it. As a matter of fact, if you don't have one long stent that can do that, start with a multiple stent with the proximal and distal edges and then stent in between. Now, also, you want to go direct stenting without balloon predilation. Or, better yet, if you feel it's too small and you want to be more conservative, you could try a balloon angioplasty, especially for distal small vessels. Sometimes, if you feel most of this is intramural hematoma and it just needs decompression, cutting balloon can be used. Now, cutting balloon is very tricky in a setting of SCAD. So you don't want to overdo it or create a perforation. So you have to be careful about the size of it. Ultimately, you could use bioresorbable stents, but there's a lot of controversy about that subject. Now, so conservative therapy is the way to go. How are we going to do it? First of all, aspirin. Aspirin is indicated, of course, and probably you need it for at least a period of a year. Some people might go indefinitely, but most probably a year. Now, what about DAPT, dual antiplatelet therapy, P2Y12 inhibition? If you did do a PCI, then according to your PCI, what kind of stents, and the guidelines for ACS with PCI, which is usually a 6 months to a year. Now, if you went with a conservative approach, most of the literature, there's a lot of controversy, but most of the literature would go with a short period of DAPT, 1 to 3 months. Beyond that, there's a lot of controversy. There are some people who advocate a year since it's an acute coronary syndrome, but there are some people who tells you this is an intramural hematoma, you don't want to do that. So again, controversy. But all agree 1 to 3 months. IV anticoagulation. Initially when they come in, you're going to anticoagulate them, but once you diagnose SCAD, you're worried about extension of hematoma, increasing that, you could actually stop anticoagulation, unless you feel that the clinical scenario or there's another compelling indication for anticoagulation. G2B3 inhibitors, a lot of controversial information. Some people might use them, some people might not. They're both teams advocates. Thrombolytics is a no-no, because again, this is an intramural hematoma, you don't want to increase it. Okay, how about other medicines? Beta blockers have been shown to be extremely useful, reduces risk of recurrent SCADs, improves the LV dysfunction, decreases arrhythmia, can cause sometimes some vasospasms, but it's the mainstay of treatment. Statins, no benefit. Anti-anginal therapy, yes, of course, but you might develop some side effects. But it's very useful for patients who are going to continue to have symptoms since they have the problem and you didn't do any intervention. Now, this is a busy slide. I'm going to skip that one. So I'll move to, actually, I'm going to go for post-procedural here. So after we do this, after we've fixed the artery, now the patient might continue to have symptoms. So how are we going to approach those patients? Again, if it's a new severe difference, it's a new ACS, I'm going to deal with it as it's a new ACS. If it's kind of atypical, I want to be a little bit more conservative, because every time I go in and do a cath, I'm injecting dye, I'm going hydrostatic dissection, I'm doing guide manipulation, so really that's not good for a SCAD. So I want to be a little bit more careful. Now, as far as iatrogenic artery dissection, again, it could be caused by guide injury, could be caused by subintimal wire injury, or sometimes balloon angioplasty itself, or stenting if you force the stent in and there's a lot of calcium. Management, usually unlike a spontaneous coronary artery dissection, you do want to lean toward the side of stenting the vessel, but you need to put a couple of things in mind. First of all, your overall flow, is it really compromised and how much? Vessel size, and the inflow of the stent, because if the inflow is compromised, that increases the risk of in-stent thrombosis considerably. So you really want to stent that, you don't want to leave it that way, and the distal runoff is the same thing. I always say to my fellows, every time we finish with our intervention, there are 5 points that you look at. You look at your guide, ostium, make sure there's no dissections. You look at the inflow, you look at the body of the stent, make sure there's no problems, distal edge, and finally, make sure there's no wire perf at the end. Now, sometimes you might go to a cabbage, but cabbage has a lot of complications, and putting or sewing a graft on a dissected artery is a very, very challenging job. So in short, and as a summary, how do we approach our SCAD patients? First of all, it's an acute inpatient management. Usually, we're going to see if there's high-risk features or not. If there's no high-risk features, we're going to go with conservative therapy. What is the high-risk features? The flow, the pain, electrical, hemodynamic instability. If so, I'm going to observe them for a longer period of time. I'm not going to go discharge them quickly. They have to stay in the hospital for a minimum of 3 to 5 days because they can have a recurrent, more severe injury episode. At that point, you might require to do an intervention. So you want to keep them there for a while. If they have a high risk, you're going to go for revascularization. Ultimately, you're going to put them on aspirin, most probably indefinitely. Clopidogrel for, or let's say, dual antiplatelet therapy for 1 to 3 months, and beta blockers are the mainstay of therapy. Heparin or anticoagulation, once you've done your coronary angiography, you no longer need it afterwards. Ultimately, long-term management, few points on that. You do want to rule out vascular disease. You want to make sure, do they have vascular pathology, especially fibromuscular dysplasia? You want to also follow up with cardiology. Cardiac rehab is very important to kind of make sure they're good on the long term. Thank you. And
Thank you, Dr. Qais.
All right, questions are for later, right?
We'll keep the questions for, okay. So we'll keep the questions after the whole session. Our next speaker is Dr. Abdullah Kasasbeh. He is a consultant cardiologist here in Jordan, and he will be talking to us about left main dissection.
Okay, good evening, everybody. My patient is a 65-year-old gentleman admitted with non-STEMI. His CK was 640, his troponin was 15. His ECG showed T-wave inversion in 1 AV LV 5V6. Transthoracic echo showed good LV function without any regional wall motion abnormality. Angiography was done. This is the RCA, non-dominant vessel, severely diseased dystally. This is the first shot in the lift system, which clearly shows severe stenosis of the ostial LAD, 010, severe or subtotal occlusion of the OM1, which is probably the culprit lesion, and severe stenosis of the OM2. If you look carefully, you can notice a linear focal dissection of the left main. This is the second shot in the lift system. At that point, I asked the fellow who did the procedure to pull back the catheter and stop the injection. If you notice, the catheter is roofed and digging in the wall of the left main. At that point, I decided for bail-out stenting of the left main to the LAD. Wired the LAD. The patient at this point developed chest pain. He remained hemodynamically stable, however. Here's 4023 stent from the ostial left main to the LAD. Then I went with 2 millimeter balloon through the struts, dilated, and dilated also the OM1, 2.523 stent implanted here. Final kissing. And here is our result. Regarding iatrogenic left main dissection, causes, catheter manipulation, contrast injection, guide wires, guide catheter extension, balloons or stents, inflation, balloon rupture in a calcified lesion, imaging devices, or any combination of those. The NHLVI classification, we have 6 classes from A, the most benign, to F with total occlusion of the vessel. St. Hardy's simplified classification for left main dissection, class 1, with very focal dissection of the ostium or shaft of the left main. Class 2 with antegrade extension to the major vessels, and class 3 with retrograde extension to the ascending aorta. Dunning classification. This is also for left main, aorto-ostial dissection. Class 1, very limited ostial dissection. Class 2 with extension to the ascending aorta, but less than 40 millimeter, and class 3 with extension more than 40 millimeters. In this cohort, more than 100,000 patients, the incidence of aorto-coronary dissection, iatrogenic, 0.07%. So it's very rare, حقيقة. In this cohort, it's 0.02%. Here, 55,000 patients, the incidence is 0.09%. All in all, it's less than 0.1%, with almost 50% of the cases associated with left main dissection, and the rest with dissection of the RCA. There is no association between access site and iatrogenic catheter-induced dissection. In the transfemoral era, it was more common with transradial approach, but nowadays there is no difference. Japanese data here showing some predictors. Being a female, having complex proximal lesions, chronic kidney disease puts you at more risk of having this complication. Regarding the management and outcome, bailout stenting is the most widely used strategy to treat. Very interestingly, the medical therapy is reported as a treatment option. And regarding the outcome, the in-hospital mortality is about 8%. Take-home message, left main iatrogenic dissection is a rare complication. No association between access site and aortocoronary dissection. Bailout stenting is the most common treatment strategy and effective, particularly if dissection is not involving the aorta. Conservative strategy is reported in cases with mild dissection and good TIMI flow in the LAD and LCX. In cases of retrograde dissection involving the aorta, BCI is effective if the dissection involves either only the ostium or the ascending aorta with less than 40 millimeters. Surgery should be done for dissection involving more than 40 millimeters of the ascending aorta. However, stenting of the left main and entry site of the dissection can be considered to stabilize the patient prior to surgery. Mechanical support devices should be considered in cases of hemodynamic instability. Thank you.
So thank you very much. Moving to our third speaker, we are having Dr. Ahmed Saad from Egypt, consultant cardiologist. He'll be talking to us about STEMI/aortic cusp dissection.
Good evening. Thank you, my colleagues and Dr. Mahmoud Zrik for the kind invitation. My patient is 67 years old man. He is diabetic, hypertensive, smoker, presented with inferior STEMI. His ejection fraction was normal with akinetic inferior and infralateral walls. Went for primary PCI. That was the coronary angio. Nothing significant in the left system. Here there is a distal RCA total occlusion.
Yeah, absolutely.
So we crossed into what we thought it was the PDA. Small balloon didn't pass, so we redirected the wire into the PL, redilated. Yeah, wire position was not okay. So, it was redirected, and then thought there was some wire perforation. but the echo showed no pericardial effusion. So we stented the distal RCA. That was the result, and chest pain resolved. Again, the echo showed no pericardial effusion. But again, the patient developed severe chest pain after we went out with all the equipment. So we went in again, and we have this shot for the right coronary. It was totally occluded here from the mid segment. It could be thrombus or dissection. Actually, wiring was a little bit difficult, so we recognized it as a dissection, coronary dissection. We could pass a second wire that went into the distal true lumen. And then we pass a test balloon to see if we are okay for the distal or not, and then stented the area of the dissection. Unfortunately, the dissection extended distally, so we had to cover it with another stent. And again, after stenting, the dissection extended proximally till it reached the aortic cusp. Then at that time, we positioned another stent into the ostium and protruding into the aorta. And the stent deployed was flaring its ostium. And that was the final result. Actually, the patient at the late night developed tamponade, pericardial effusion and severe tamponade, and I went and we did pericardiocentesis for him, but he didn't need any intracoronary manipulation for that perforation. It sealed spontaneously. And thank you.
Thank you. So moving, thank you. We'll keep the questions for the last. Finally, we will have our friend Dr. Ahmed from Palestine talking to us about a case of postpartum STEMI.
Egyptian styles, last two cases.
Yeah. Hello, good afternoon. Thank you all for having me. And the good news, I'm the last one. Well, our case is obvious from the title. It is a postpartum spontaneous coronary artery dissection. Our patient is a 32-year-old lady, presented with chief medical complaint of chest pain, shortness of breath, palpitation. She had been having those symptoms for the past 2 days after delivering a normal baby. She presented to the hospital with acute worsening of her symptoms. She have no past medical history. She never smoked, takes any medications. She relatively does not have any history for a significant premature coronary artery disease. On the examination, she was moderately distressed, no GVP, slightly tachycardic, but no murmur with good equal air entry. The ECG shows sinus tachycardia, minimal ST segment elevation, the AVR with a global ST segment depression, and the labs was positive for troponin. We did a very quick initial ECG, and you can notice the LV is slightly dilated with a segmental wall motion abnormality in the apical, anterior, and anteroseptal wall. Maybe the ejection fraction was around 30. We rush her to the cath lab, and this is the cath lab. Obviously, the RCA have no significant lesions. We did the lift system, and this is what we got with the lift system. Maybe there is a mid to distal narrowing in the lift system. Nothing significant. the first thing will jump to your mind, what I have to do with this patient. And if you can notice from the angiography, there is a hypokinesis in the anterior and anteroseptal wall. So the question at this point, what is the optimal management? Do we conserve? Go for a PCI because of the troponin? Could be a Takotsubo and we need an LV angiogram. Well, the diagnosis isn't clear. Do we need an IVUS? The patient in heart failure, should we treat the heart failure and leave her? The presentation here most probably caused by coronary artery dissection by a SCAD, but the chest pain improved. It is the middle of the night. We have a good distal flow. Maybe it is a moderate left main lesion, so we decide to keep this patient for conservative management. So to catch up, the spontaneous coronary artery dissection, spontaneous tear in the coronary does not caused by an trauma or iatrogenic. It's around 1.7 to 4% of acute coronary syndrome. It's overwhelming in the women. And the types, we all understand the types. Type A, you see the classical flap. Type 2, it is a very long narrowing, more than 20 millimeter in diameter. And the type 3, it is a focal narrowing. Sometimes in type 3, you need to do intravascular imaging. But here's the catch. If you are certain about the diagnosis, it's better not to manipulate the artery and leave it to heal. Well, the natural history for the SCAD, the spontaneous coronary dissection will spontaneously heal, even though if you don't have a very optimal flow. And here's comes the consensus of the American Heart Association. If the patient's hemodynamic stable, if you have a STEMI flow of 2 or 3, you go for conservative management. End of the story. If you have a left main coronary artery dissection or the proximal LED dissection, and the patient is still dynamically stable, maybe the conservative management will be a good option. If you don't have flow, if there's ongoing ischemia, you have to do something. So 12 hours later, the patient developed severe chest pain, became hemodynamically unstable, an extensive anterior ST segment elevation, and here is the catheterization. You will notice there is much narrowing. There is an extension of the hematoma in the left main, compressing the left main. The LCX flow is good. The LED, there is a tampering in the flow in the LED. I go with a guide catheter, wiring both the LED, the LCX. We go for direct left main stent to from the left main to the LED, and this is what we got. Extensive distal dissection, we lose the flow in the LED. First of all, you don't need to panic. Try to fix the problem. We go distally with another stent, we inflate the stent, we obtain the flow. The patient relatively stable. If you notice there is a dissection extended to the first diagonal branch, I decide to leave it alone. Then I recross to the LCX because there is a lot of haziness in the LCX origin. We did a kissing balloon and we finish the intervention. And this is our final result. So take home message. The diagnosis sometimes is not clear. Intravascular imaging may be help. The majority of SCAD will heal spontaneously. In the high risk, and you have to anticipate a high risk PCI and a technical failure, particularly the extension of the dissection will happen most of the time. Even CAPG result is not good in the dissection. The conduit failure is very high, and sometimes there is something need to be done, and most of the times the BCI will be the answer. Thank you very much.
So again, we thank our speakers because I think the most important sessions usually in major conferences are the complication sessions, because we repeat what we said yesterday. It takes some bravery from the presenters to share with us their bad experience, and this is the most learning for us. So thank you all. If anybody will open the floor for the panelists.
Thank you very much, Dr. Raad. My question to Dr. Abdullah, do you think from the daily practice, Dr. Abdullah is present?
Can we have the speakers here in the front so we can, please, go ahead. Hey, Dr. Abdullah.
يمكن Dr. Ahmed, the left main dissection, left main dissection.
Left main
yes.
dissection.
Do you think that the type of the there is no clear difference between using femoral approach or radial approach for the iatrogenic left main stem dissection or dissection in general? I think in the guideline and the trials, yes, there is no clear difference, but for those fellows and who are using radial or beginner of using radial approach, in our practice we see there is an increased risk of iatrogenic dissection when they are using radial and over manipulation. But in expert hand, sure there is no clear difference. Do you agree with this?
I agree with you. Yeah,
yes.
I agree.
For Ahmed Said to finish with me, Ahmed Said.
Dr. Ahmed.
Dr. Ahmed.
Stand up.
أنت
Stand up.
أحمد يا حبيبي. I think for the you did a lot of stenting in the RCA, and you didn't show us a lot of orthogonal view for the RCA from the beginning to see the flap from the beginning, because the aorto-ostial dissection in the RCA, and there is no apparent, it was like a healthy visual proximally. We should suspect that from the beginning, and we should take a lot of views to discover and to start from the aorto-ostial. The last stent it is a proximal, just to pull it to aorta and to finalize the case without thing from the beginning. Just to taking a lot of pictures and view in a different way to show that section.
Too much injections will expand the dissection.
Sure.
It will make recrossing more difficult.
Sure, but you can see the staining from the beginning, and
It was not in the proximal. The staining was just in the middle. So we thought initially it was a thrombus. So we tried to wire. At that time we realized it is a dissection. So we have to limit the injections.
That's the most important tip and trick, is that you don't depend on not for you, for us, don't depend on your assistant to inject or to use the contrast. Use the contrast by your hand, because sometimes the assistant push forcefully, especially in the RCA, and they are making dissection. So this is one of the important points. And don't inject against the wall of any vessel. We should be so soft. The coronary arteries are very soft. We should be so soft in dealing with coronary artery. Thank you. Very nice case.
The dissection expanded from the middle of the RCA. It was like a propagation from distal to proximal that reached the cusp. It was not a guide catheter induced. It was after stenting. Before stenting, there was no dissection. It was only limited to the middle of the RCA. Once we stented, it propagated distally and proximally. And then
I think what happened with you is exactly what I was talking about, the toothpasting. Toothpasting, what I mean is, do you know when you the toothpaste tube, what you do is you roll it عشان يطلع التoothpaste من هاي. You continue to roll, بيطلع toothpaste. So that's exactly what's happening. You're stenting, and the blood is being pushed, and it dissects more. That's why they call it toothpasting. You know, so it's the hematoma propagation. As you're compressing with the stent.
It was not a hematoma. It was type A dissection. It was not type 2 or 3. It is type A.
There is blood in there. There's blood in the dissection plane.
Yeah, but it was a type A dissection. The flap is separated from, there is an entry and exit point. That's why it is not contained inside the vasa vasorum or the media. And
but still even with the hematoma, you might still have ruptures, tears. Sure. Yes, you're gonna have that.
Or maybe, Doctor, my question for you, Doctor. I think when you realize that it's a dissection,
it was preferable to wire the RCA without a total cannulation, because probably it was from the beginning in the false lumen, and the wire was exit in the middle or after the mid RCA, then you went to the true lumen. So first stent, second stent, maybe you was in the false lumen. That's why the artery was occluded. Maybe you had to be much non-selective in the RCA to wire the RCA to avoid being in the dissected segment.
But
or
you have
in the
to be
false
selective cannulating the RCA, but you have to be a coaxial, not non-selective, because if I'm not selective, how can I know I'm going inside the vessel? I have to be selective cannulation, and especially if the patient is having chest pain and ST elevation on the monitor. So I have to selectively recannulate again and inject to see what's happening inside. And then I found that dissection. I cannot disengage again and try the wire. No, I went with the wire directly. But we have to make the guiding catheter coaxial with the vessel, so not to make an iatrogenic dissection.
In your case, after you localize the dissection of middle RCA, I think it's proper to put a stent more distally to avoid forward propagation of the problem. And I ask you, you think is the dissection is extension of the stent, dissection induced by stent, or it is the original dissection extended?
I cannot tell what is the exact pathophysiology going on. Is the dissection, it's an edge dissection or a propagation from the previously dissected segment? This is the pathophysiology. I cannot say which one is first, the egg or the chicken. But already I have a dissection there. So I put the stent to seal the entry and the exit. That was the middle stent. And then the dissection expanded distally, so I have to follow and the stent distally. And the dissection expanded proximally, so I have to follow also on the stent and seal until the aortic cusp, because already the dissection extended into the aortic cusp.
But sometimes we have to go more distal to prevent extension of dissection.
Yeah, you have to go to seal the exit, the entry and the exit of the dissection.
Yes, okay. I have some simple questions to Dr. Qais. We have the dilemma how we can differentiate type 2 and type 3 dissection from the coronary atherosclerosis. And sometimes we discover that only after crossing of the wire in the false lumen.
Yes. So that's an excellent
Muntasir. Let us answer first.
Yes, that's an excellent question. Unfortunately, the answer is difficult. So one way is to do, the IVUS to confirm. But your major question was you are trying to even avoid wiring, because if it is a spontaneous, you don't want to really hurt the patient. I think clinical scenario is going to be the answer. If you have a sick patient, and he's a lot of symptoms, you're going to have to wire that and confirm. If it goes more with a spontaneous artery dissection patient, young, female, pregnant, hormonal change, trigger, makes me think, maybe there's no, all other segments are healthy, only this focal point, RCA, otherwise are normal, then it goes with spontaneous artery dissection. If I think it's going to limit the flow down the road, I might do IVUS, as I said. But yes, you have an excellent point. So the way to go is clinical scenario and then IVUS or OCT.
Of note, we'll accommodate all questions and comments, so don't worry about that. Please, go ahead.
Okay. Actually, this session, we can label it as ختامها مسك. All the cases were really interesting. My question mainly to Dr. Ahmad. First, I'm proud to have such a colleague from my country, Palestine, so well done, Dr. Ahmed. Two things. First of all, I want to stress on the dynamic thing of diagnosis. All directions was toward Takatsubo from the beginning, actually. But once there is some new findings, then we have to rethink this one thing. The other thing, yesterday in my case, because it reminded me in my case, actually, Dr. Raed, you remember,
yes, absolutely.
And one suggestion from Dr. Adil Atrabi yesterday, why don't you just stop the Samburi from the proximal, do stent and خلاص, and why to start from the distal? And I like the exhibition of toothpaste, that the extension was there, and it happened with Ahmed actually. Then he had to go distally and stent. So I mean, sometimes it's not always just occlude the proximal and then you will stop it automatically. Any comment? Ahmed?
Well, exactly. Well, my case is a deja vu of your case. It is almost exact cases, but with different scenario. Well, I did my fellowship in Egypt. I learned the Egyptian way. So when we face a dissection, we try to seal it from the proximal. We extend it to the distal as minimal as we can. We don't need to put a stent from the beginning to the end. We don't need to cover all the vessels. If you can fix it with 1 or 2 stents, this is better than over-stenting. And bear in mind, this is the problem with the vessels. It will heal spontaneously, obviously. And you will leave this patient with 4, 5, or 6 stents. And sometimes you wonder if those stents are getting any problem. What is the options? So first of all, spontaneous, maybe the scenario will lead you to the diagnosis. If you have doubts, you have an IVUS, go for an IVUS. But if it is match the scenario, I think if you decide to go for conservative management, it's better not to manipulate the artery. Even with an IVUS, even with an OCT, even with a wire, leave it. It will heal. And this is what the studies show. With those who, even with suboptimal flow, they will improve. They will improve with a couple of months, maybe.
1 month. Actually, the majority will heal within 1 month.
Exactly. Thank you, Ahmed. I got a small question for the panelists. Usually when I face those cases, I advise those patients to go for screening, do a renal angiogram. And I did for them an ESR. If an ESR is elevated, I advise them to go and see a rheumatologist. Do you have any position in those things?
So your question, do we have any guidelines for spontaneous coronary artery dissected patients to rule out other vascular phenomena in different beds? Any takers?
Yes, I'll take
Please, Ahmed.
Just 2 points before I start. With the idea of stenting the ostium of a dissection was proposed by Antonio Colombo, but after he stented the ostium of the dissection, he did FFR to make sure that the flow in the rest of the dissected artery was okay. Now, there was a study, 585 patients who had SCAD. They found 40% incidence of FMD.
Yes.
Actually it was 58% FMD and 40% they had migraine. So I want to just talk a little bit about this because we keep talking about treatment. What about paying some attention? Which women, we know 25% of women under the age of 50 who come with ACS, they have SCAD. They found some association with migraine. So maybe we should be looking more at those patients or pregnant females who have history of migraine. There was also association with hormonal therapy. Those patients who took hormones to get pregnant. And the third association was with using tocolytics during delivery. So maybe those patients, we should cut down stage 2 of labor, which we know has a lot of effect on the blood pressure and the heart rate. I don't know, maybe those ladies should go for C-section. Maybe they should have closer monitor. If I have migraine, I'm pregnant, maybe I should have a renal ultrasound looking for FMD.
So Ayman, you didn't answer the question. Would you go ahead and do any imaging for other vascular beds in people with spontaneous coronary artery dissection?
If I give you 60%, the answer is obviously yes.
Okay.
Yes,
any other takers, please, Doctor?
I have a comment and a question to the panelist regarding the proximal extension of a dissection that we covered the entry. It mostly is the hematoma extending into the wall, which called the toothpaste effect. And if we have IVUS, there is a solution. I don't know if any one of you could try that. If it's a hematoma in the wall, we can use a scoring balloon to induce a therapeutic dissection to drain this hematoma. And if good flow, no need for further stenting.
Yeah, I think this is a kind of theory that makes sense, but I am not sure we have any data on that.
There's been reports of cases, people who've done that, but nothing like study.
So I have a question for you, Qais. First, I have two little comments. When you do an echocardiogram during a perforation, the echo will rule out hemodynamically significant effusions, but the effusion is there. And this is why we need to keep these patients and follow them with serial echos. Second thing, any dissection that happens during your procedure, which is iatrogenic, and you use automated injectors, stop that automated injector and move to the hand, very soft injection. A comment to you and a question. If it is the mechanism and intramural hematoma, what's the wisdom of using aspirin?
All right, that's an excellent question. And that's why the whole debate about anticoagulation and about dual antiplatelet therapy and all that. So the idea, quote unquote, is because of the compression, you're going to have slow flow. Slow flow is going to be a prothrombotic process, so you want to try to prevent that propagation. You want to try to prevent microthrombi formation in the distal circulation. So you use the least offensive medication, which is aspirin. And this is by consensus. There is no studies to look for that.
Okay. Second question, 5 things you told your fellows to look at the end of every procedure. Please repeat them.
So 5 things. Number 1, look at the ostium of your coronary where your guide is sitting. Second, your inflow of your stent. The stent itself, is it well expanded? No clots, no haziness. The end of the stent to make sure there's no distal edge dissection. And then the runoff, make sure there's no wire perf or complication.
And we might add the 6th one. Look at the patient.
Of course.
Sure, Dr. Raed, just to add something also. So in conclusion, I think it is important to say that the most of iatrogenic, away from the SCAD, the most of the iatrogenic dissection is preventable. This is number 1. So the most of the important thing, they are preventable. We should be so careful in dealing with the coronary arteries, using of fire escalation, using of forceful injection. And the other important thing is that you should be courage and not be so hesitated and to keep your wire in. This is very important, and sometimes IVAS or imaging is necessary. Thank you very much, Dr.
Thank you. I used to have a attending at the Mayo. His name was Rihal. I don't know if you know him, Chet Rihal. Yeah. He used to tell me, the wire is your friend. You never push it, you never pull it.
That's right, sure.
Thank you, guys.
Thank you.
الله يعطيكم العافية. أبدعتم جميعا. يعني حضور مش بطال اليوم، مع إنه يوم الجمعة. طبعا أنا راح وزميلي الدكتور أيمن حمدان موجود. closing remarks راح تكون أنت اللي تنهي المؤتمر، بس بحب أحكي لكم إحنا راح نضلنا على اتصال مع بعض. غالبا العام القادم إذا ضلينا عايشين إن شاء الله راح تكون بجولاي، لأنه آخر جون بصراحة في مؤتمرات بتوقع في وسط جولاي بتوقع مناسب. Do you agree؟
Yeah.
يعني أنسب وقت. فتفضل دكتور أيمن.
Before I start, I want to just give a round of applause to Dr. Mahmoud Zreik because he single-handedly did most of the work. Ladies and gentlemen, as we bring this enlightening scientific conference to a close, I am filled with gratitude for the collective wisdom, insights, and innovations shared within these walls. The presentations, discussions, and collaborations that have taken place over the past 2 days have not only expanded our knowledge, but have also kindled new avenues of discovery and progress in the field. Our journey together has been nothing short of inspiring as we explored new frontiers, challenges, existing paradigms, and laid the groundwork for future breakthroughs. The passion, dedication, and expertise demonstrated by each of you exemplify the spirit of scientific inquiry and the relentless pursuit of excellence. As we disperse and return to our respective corners of the world, let us carry forward the momentum of this conference. Let us continue to nurture the seeds of innovation planted here, collaborate across disciplines and borders, and strive towards solutions that benefit humanity as a whole. I would like to express my heartfelt thanks to all the speakers, organizers, sponsors, and participants who have made this conference a resounding success. Your contributions have not only enriched our understanding, but have also strengthened the bonds of our global scientific community. In closing, let us remember that the greatest discoveries often emerge from convergence of diverse ideas and perspectives. May the connections forged here inspire us to reach greater heights, push the boundaries of knowledge, and shape a brighter future for generations to come. Thank you all, and safe travel back home. Let us look forward to meeting again, guided by the spirit of curiosity and collaboration that defines us as scientists and innovators. Thank you again.